IgA vasculitis. Previously we called it Henoch purpura. It is diagnosed with the palpable purpura and any of the following four: abdominal pain, arthalgia or arthritis, and nephritis, hematuria, proteinuria, azotemia, hypertension and others, and IgA dominant deposition on the renal biopsy. Dominance means most of the time we understand 2 plus or more, 2 times more intense than any deposit else. So purpura in IgA vasculitis is predominantly in the lower extremities and gravity dependent, and usually it spares the upper part, but it's possible to have the widespread disease when the disease is little bit extensive. So if you do the biopsy which is said to be diagnostic leukocytoclastic vasculitis, that means aggregated nuclear debris in histology, small common in the boys than girls. It is synpharyngitic or postpharyngitic, 1 to 2 days after you got throat infection, or 1 to 3 weeks after this pharyngitis, and also possible to be post-gastroenteritic and syngastroenteritic. Viruses and the bacteria involved over here: adenovirus, streptococcus, staphylococcus, mycoplasma. It's also B and C, and it's more common in the winter. The insect bites, this also can be an inciting events. The gut is involved, 50 to 70% of cases. Brain can be involved, orchitis can be there, epididymitis may be there, and urethritis can be there, and carditis, myositis, lung bleeding is also possible. In worst possible cases, acute anterior uveitis is also possible. That is, it is a systemic disease in a small subset of cases. Good amount of cases you have mild presentation and disease comes and go, so people do not recognize it. It's quite common. And then kidney involvement has presentations like isolated hematuria, gross hematuria, microscopic hematuria, and your proteinuria, hypertension, the impaired renal function. Even CKD, ESRD, sedimenturia, all are possible. Recurrence and relapse is also possible. So there is no definitive diagnostic test. So as I said earlier, one purpura plus any of the one of the four: arthritis, arthalgia, nephritis, IgA deposition, and abdominal pain. So how to treat these cases? The milder cases, you use your RAS inhibitor, that is S inhibitor or ARB, either. In more milder cases, you can avoid giving anything. It comes and it goes. No symptom, no residual, no organ involvement, no renal involvement. So they do not need to give anything. And when disease is a little bit more advanced, you have GFR reduction, but still it is more than 50 ml per minute per 1.73 meter square. The proteinuria is also significant, 1 gram or so. You give oral prednisolone. When it is a little bit more aggressive, now disease is more, a little renal involvement is a little bit more. You have more proteinuria. You have renal impairment. You have more, your systemic symptoms. Give IV methylprednisolone and followed by your cyclophosphamide, in there, or and other one. In the more severe cases, you can use the MMF, but MMF and azathioprine, they are the drugs to use mostly for the maintenance of the immunosuppression. And you can also combine with CNA, cyclone tacrolimus, in sequential manner, and see the response pattern and decide your next therapeutic option. So persistence, proteinuria, you need to combine with it the rituximab. So finally, you have like every other disease, plasmapheresis, a good option, and it is a drug which said to be has reduced CNS CKD progression. And the anticoagulants like the heparin, warfarin, and dipyridamole, they are also useful in worst possible cases, and they prevent the CKD progression, mostly when the disease has RPGN presentation. So, and the small subset, very small subset of patient reaches ultimately your end stage, they are to be transplanted. Recurrence is possible, small 1/3 of the cases, and 10% at has graft loss in those cases, and treat them in standard fashion as you do in other cases.